Hi, I'm Tim Lovell, and I want to talk to you about your upcoming hip replacement. I want to tell you all about what we're going to do, talk about potential risks and complications of the surgery, and then I'm going to come back in and answer all your questions, and then we will do our consent form for surgery. So first, we have you set up for a hip replacement, and I would encourage you to have a spinal for anesthesia. That's where they numb you up from the waist down. Now they also will give you medicine through your IV so that you sleep the whole time. But if you can have a spinal, we would recommend that. And anesthesia will talk to you about that on the day of surgery in the hospital. So once you're comfortable, we're going to make an incision that's not right in the front of the hip, it's not right on the side, it's kind of in between. And we go into the hip without going through or across any muscles or tendons. We pull them out of the way. Your hip, your current hip, is a ball on a socket. We are going to take out the bony ball and put in a hip replacement. And a hip replacement is a rough metal socket, rough metal, so your own bone ideally grows into this rough metal. And pretty commonly we put a couple screws through these holes up into the bone to help hold it to the bone. There is then a plastic liner that goes inside this metal socket. All of our bones are hollow tubes, so your femur or thigh bone is a hollow tube. And in the hollow tube of the femur thigh bone, we put a rough metal stem, is the word we use. And it's rough metal, so your own bone ideally grows into that rough metal. And then we put a ball onto that. That's a hip replacement. Once the parts are all in there, we close you up. You go to the recovery room for a couple of hours, and then you go up to your room on the floor, and we can get you up walking the same day or the next day. You're typically then in the hospital for 1 to 3 days. So for example, if your surgery was on a Tuesday, we would let you go home Wednesday, Thursday, or Friday, depending on when you and the nurses and therapists agree that you're safe and ready to go home. Now, it doesn't matter to me if you go home 1 day, 2 days, or 3 days after the surgery. What matters to me is that you're safe to go home. Having said that, we do try to get you out of the hospital as quickly as we can to get you away from all the resistant bacteria that live in the hospital. So honestly, if you're ready to go home the first day after surgery, we're happy to have you go home after that first day. It's not because we're trying to kick you out of the hospital. We want to get you away from all the resistant bacteria that live in the hospital. Now, initially we're going to get you up walking with crutches or a walker, and I let you and the therapist decide if you're safer with crutches or with a walker. And I'm going to have you put half of your weight on your operated leg for the first 3 weeks. And sometimes we vary that, but typically for 3 weeks we have you on crutches or a walker. Then you'll go to a cane. And for example, if it was the right hip, you would use the cane in your left hand. You would then use the cane until you can walk without a limp. And the reason is, if you're limping, it puts more stress on the parts. So if you're limping, I actually do want you to use a cane. Now, for you to get as good as you're going to get after one of these, honestly takes 2 to 3 years. There's a Mayo Clinic study that says it takes 3 years to get as good as you're going to get after a hip replacement. Now, I typically will let people play golf in 3 months. So most of the getting better happens pretty quickly, but you should feel better 2 years from now than 1 year from now. Anytime you have surgery, there are risks. And I'm going to tell you these things not to make you nervous. It's just so you know what's going on. Anytime you have surgery, there's bleeding, and there is a chance you could need a transfusion. Anytime you have surgery, there is a risk of infection. We're going to give you antibiotics through your IV just before we start surgery and for the next day, and that helps decrease the risk of infection to less than 1%. If you were, though, to get an infection, if it happens in the first few weeks after surgery, it sometimes can mean another surgery to wash it out, and up to 6 weeks of IV antibiotics. And sometimes that will take care of it. If it did not take care of it, or if you were to get an infection a few years from now, then it's typically a minimum of 2 surgeries to get rid of the infection. It's a big deal. First surgery, we have to go in and take out all the parts and thoroughly wash and clean out the hip joint. Then we would give you 6 weeks of IV antibiotics, and 3 or 4 months from the takeout surgery, we would come back, and if the infection were all gone, then we could put final parts back in. Again, it's a big deal if you get an infection. Anytime after this that you have any dental work done, even a routine cleaning at the dentist, we want you to take antibiotics by mouth an hour ahead of time. And the reason is in all of us, when we have dental work done, bacteria get in your bloodstream. It's very rare, but occasionally they will stick to the parts and cause an infection. So an hour before you have dental work done for the rest of your life, we want you to take some antibiotic pills. And either the dentist can call that into your pharmacy or our office can call that into your pharmacy. Anytime you have surgery, there is a risk of damage to blood vessels or nerves. We are working right on top of all the big ones here, and we know that. And we are paranoid about protecting them. Risk of injury to the big blood vessels or nerves is less than 1%. All of us, though, have a skin nerve that is right on top of where I'm working. And it gives you feeling down in the bottom outside part of your thigh. I have to stretch that skin nerve out of the way to do the surgery. Up to 10% of the time, that skin nerve can say, hey, you stretched me, I quit. So there is up to a 10% chance you could be permanently numb on the skin of your thigh down near your knee. You will be numb right near the surgical incision. Anytime we make an incision anywhere in the body, the little tiny skin nerves just below the skin get cut. So you will be permanently numb right near the surgical incision itself. Anytime you have hip surgery, there is a risk of getting blood clots in the veins of the legs. We take those very seriously because rarely they can break off and go to the heart of the lungs, and extremely rarely people have actually died from that. So we do everything we know how to prevent blood clots. We're going to put you on a blood thinner after the surgery. We're going to put these lovely white TED hose stockings on. While you're in the hospital, we put these squeezers on your lower legs that help pump the blood up. As soon as you wake up from surgery, I want you to start moving your feet up and down, and we have you move both feet up and down. The other thing we do is we try to get you up walking right away. So we do all 5 of those things to help prevent blood clots. Now, whenever you have an artificial hip, you can pop the artificial ball out of the socket. We call it a dislocation. And the risk of dislocation nationwide is considered 3%. The problem that we have is there is literally no hip replacement made that cannot be popped out. Every single one of them, if you move the wrong way, it will come out. And we're going to show you what to do and what not to do. But the big no-nos involve twisting, and I'm going to show you the 2 things we really don't want you to do. The first one is we don't want you to be sitting, bend forward, and twist towards the outside of the foot that you had your surgery on. That is one of the things that will pop it out. The other one is if you're standing, and I'm going to show you that again. If you're standing and you leave the side we did surgery on that foot planted and hyperextend and twist, it's the twisting that pops these things out. So we're going to have you avoid twisting. Whether you're standing or you're sitting down, we want you to avoid twisting. And the therapist will show you what to do and what not to do while you're in the hospital. Now, if you do move the wrong way, though, and pop it out, it hurts like crazy. We have to take you back either to the operating room or put you asleep in the emergency room, pull on your leg and pop it back in. That's not the real problem, though. The real problem is that once you pop it out once, you are more likely to pop it out again and again and again to the point you could actually have to have another operation. So we do want you to be careful how you move, and we will show you exactly what to do and what not to do. Now, whenever we do a hip replacement, one of our goals is to have your 2 legs end up exactly the same length. The problem that we have is it turns out the single best way to make it hard to pop the ball out of the socket has a side effect of lengthening your leg. So it's very common at surgery that I have this dilemma of, on the one hand, do I make your legs the same length, which is a good thing. Sometimes, though, that makes it a little easy to pop the ball out of the socket. On the other hand, the other option is to make the leg I'm working on longer, and then it's pretty hard to pop the ball out of the socket. That is a very common situation we get in when we're doing a hip replacement. If that's the situation, it's not a dilemma. If that's the situation, I will purposely make the leg we're working on longer, because you can live with a shoe lift in your other shoe. You may not like it, but you can live with it. You cannot live with a hip that keeps popping in and out. Now, I will tell you, our goal is perfect. We're not aiming for close. We want your legs to end up perfectly the same length. Sometimes I don't have a choice. Sometimes I have to make your leg longer so it won't pop out. Now, I will tell you that almost everybody initially feels a mile too long. So I don't want you to worry if you get up to walk the day after surgery and say, oh my gosh, the leg they worked on is 10 inches longer than the other one. I can't do that. I can't make you 10 inches longer on the leg we're working on. But even if you're perfect, almost everybody initially feels too long. And that feeling of being too long will get better, but it takes a good 6 months. Now, whenever we put this piece in the femur or thigh bone, we're trying to wedge it into the bone as tight as we can to maximize chances that your own bone will grow into the rough metal of the part. So that part is literally wedge-shaped. Now, what happens when you put a splitting wedge in a piece of wood? It splits. Same thing can happen to the femur or thigh bone. It can break. And if it does, we fix it. We put cables around the outside of the bone to lock the bone together, kind of like a hose clamp would work. Sometimes I even have to make a separate incision to do that. Now, whenever we put anything artificial in the body, one of two things has to happen. Either you're going to outlast the parts, or the parts are going to outlast you. Now, what we all want is for the parts to outlast you. The problem is they are just artificial things, and it is possible for them to wear out or come loose from where they attach to the bone. And if that happens, we just go back and redo them. Now, the good news is these parts are so much better than they used to be that as long as your own bone will grow into the rough metal of the parts, which it usually does, there is a chance this could still be working well more than 20 years from now. I can't guarantee that, but that's what the data seems to suggest at this time. Two last things. Anytime you have surgery, there is a risk of heart attack, stroke, pneumonia, bladder infection, things like that. Anytime we do a hip replacement, there is a small percentage of people who don't like the result as well as they had hoped. Now, the good news is most people love their new hip replacement, but there is a small percentage of people who say that they don't like it as well as they had hoped it would turn out. The last thing is, even if everything goes perfect, nothing I do can make you like you were when you were 16. So I will be in a few minutes to talk to you more, and I want to answer all your questions. So if you think of any, even after we're done with our meeting today, please write them down. I don't care if you come on the day of surgery with 10 pages of questions. I will go through every single one before we do the surgery. Thank you.